Welcome students. Students identified as visually impaired represent a wide range of visual abilities. However, they share one common characteristic, a visual restriction of sufficient severity that it interferes with normal progress in a regular educational program without some modifications. From a medical perspective, if the vision problem is left undetected and not corrected, it can cause permanent loss of vision and the long-term consequences can be serious in terms of quality of life. Assessment is an essential component in the educational program for all children. In this unit, let us see about the interpretation and integration of information gathered from clinical assessment, which is a key factor in comprehensive assessment of visually impaired children so as to make informed decisions about their individual educational program. Interpretation of clinical assessment of vision. Vision is the process of receiving stimuli transmitted to the eye and then to the brain, and translating those stimuli into the images. Because vision plays such an important role in a child's early development, identification of vision impairment in young children is especially important. There are several basic aspects of vision such as form perception, color perception and motor perception. Vision impairment is loss of some aspect of vision and can occur as the result of a problem at any point along the visual pathway. Some vision impairments may be easily corrected with glasses, surgery or other medical interventions. Other vision impairments may not be correctable. Now we will see about assessment of visual acuity. The first part of the eye exam is an assessment of acuity. This can be done with either a standard Snellen hanging wall chart read with the patient standing at a distance of 20 feet or a specially designed pocket card held at 14 inches. Each eye is tested independently, that is, one is covered while the other is used to read. The patient should be allowed to wear glasses and the results are referred to as best corrected vision. One need not assess the ability to read every line on the chart. One can rapidly skip down to the smaller characters. The numbers at the end of the line provide an indication of the patient's acuity compared with normal subjects. The larger the denominator, the worse is the acuity. When describing vision, most people tend to think of good, that is normal vision, as the ability to see clearly at all distances without glasses. This is commonly referred to as 20 by 20 vision. The expression 20 by 20 is a description of visual acuity based on how clearly images such as letters, numbers or pictures are seen on a standardized eye chart, that is referred to as an optotype. The first standardized eye chart designed to measure visual acuity was introduced by Herbert Snellen in 1862. Although the Snellen eye chart was introduced well over 100 years ago, it is still the most common way to measure and report visual acuity. The expression 20 by 20 refers to a person's visual acuity using the Snellen eye chart. This is the eye chart that is commonly used for obtaining a general measure how well someone is able to discriminate visual images at different distances. The Snellen visual acuity rating is written as a fraction. The numerator, that is the number in the top, is the testing distance, usually 20 feet or 6 meters, but sometimes less for small children, that is 10 feet or 3 meters. The denominator bottom number is the distance at which a person with normal visual acuity would be able to read the letter. For example, a person with 20 by 20 vision sees at 20 feet what a person with normal visual acuity sees at 20 feet. A person with 20 by 30 vision can see clearly from 20 feet what a person with normal visual acuity is able to see at 30 feet. A person with 20 by 200 vision can see clearly at 20 feet what a person with normal visual acuity is able to see at 200 feet. If the patient is unable to read at any of these lines, it is indicative of a big problem. A gross estimate of what they are capable of seeing should be determined. The first assessment of visual acuity is distance visual acuity. Equipments needed for this assessment are multi-letter Snellen or E-chart, plain occluder, card or tissue, pinhole occluder, torch or flashlight, patient's documentation. We will see about the procedure. Ensure a good natural light or illumination on the chart. It is important to ensure that the person has the best possible chance of seeing and reading the test chart, as treatment decisions are made based on the results of visual acuity testing. If the test is done outdoors, the chart should be in bright light and the patient in the shade with enough light to illuminate the patient's face during the test. Explain the procedure to the patient. Tell patients that it is not test that they have to pass, but a test to help us know how their eyes are working. Tell them not to guess if they cannot see. Ensure that any equipment that the patient touches is clean and is cleaned between patients. Infections can be passed between patients if equipment or the tester's hands are not clean. Position the patient sitting or standing at a distance of 6 meters from the chart. The patient can hold one end of cord or rope of 6 meters long to ensure that the distance is maintained. Test the eyes one at a time, at first without any spectacles. Visual acuity should be measured from a standard distance using a standard chart with a white background. Ask the patient to cover one eye with a plain occluder, cord or tissue. They should not press on the eye. This is not good for an eye that has undergone surgery. It can also make any subsequent intraocular pressure reading inaccurate and it will distort vision when the occluded eye is tested. Ask the patient to read from the top of the chart and from left to right. If the patient cannot read the letters due to language difficulties, use an e-chart. The patient is asked to point in the direction of the legs of the E are facing. The smallest line read is expressed as a fraction. Example 6 by 18. The upper number refers to the distance the chart is from the patient, that is 6 meters, and the lower number usually written next to the line on the chart is the distance in meters at which a normal eye is able to read that line of the chart. Incomplete lines can be added to the last complete line. For example, 6 by 12 plus 3 indicating that the patient read the 12 line at 6 meters and gained 3 of the letters on the 9th line. Record the visual acuity for each eye in the patient's notes, stating whether it is with or without correction, that is spectacles. For example, right visual acuity is 6 by 18 with correction, left visual acuity is 6 by 24 with correction. If the patient cannot read the largest letter at 6 meters, move him or her closer 1 meter at a time until the top letter can be seen. The visual acuity will then be recorded as 5 by 60 or 4 by 60. If the top letter cannot be read at 1 meter, that is 1 by 60, hold up your fingers at varying distance of less than 1 meter and check whether the patient can count them. This is recorded as counting fingers, that is visual acuity is counting fingers. If the patient cannot count fingers, wave your hand and check if he or she can see this. This is recorded as hand movements, that is visual acuity is hand movements. If the patient cannot see hand movements, shine a torch toward the eye and ask if they can see the light. If they can, record perception of light, that is visual acuity is perception of light. If they cannot, record no perception of light, that is visual acuity is no perception of light. After testing without any correction, test the patient while wearing any current distance spectacles and record the visual acuity in each eye separately with correction. If 6 by 6, that is normal vision, is not achieved, test one eye at a time at 6 meters using a pinhole occluder. The use of the pinhole reduces the need to focus light entering the eye. If the vision improves, it indicates the visual impairment is due to irregularities in the cornea, a problem in the lens or refractive error, which is correctable with spectacles or new prescription. Repeat the whole procedure for the second eye. Summarize the visual acuity of both eyes in the patient's notes. For example, that is right visual acuity is 6 by 18 without specs, 6 by 6 with pinhole, and left visual acuity is no perception of light. And now we will see about the interpretation of clinical report in the board. Can see the 18 line at 6 meters or better, that is mentioned as good vision, that is 6 by 6 to 6 by 18 is good or normal vision. If the patient can see 24 line at 6 meters at best and the 60 line at 3 meters at worst, the vision is mentioned as poor vision, that is 6 by 24 to 3 by 60 is poor vision. If the patient cannot see the 60 line at 3 meters but can see a torchlight, the person is mentioned as blind. 2 by 60 to perception of light is blind person. Then the person cannot see light, the person is mentioned as blind to light, that is no perception of light. Now let us move on to the second test of visual acuity, that is near vision acuity. There are three principal measures of near visual acuity. First one is unaided near visual acuity or near vision. Second is habitual near visual acuity with the patient's own spectacles and optimal near visual acuity with the best refractive correction. Habitual and optimal near visual acuity are routine measurements in presbyopes and all patients with complaints of near vision problems. Measuring unaided near visual acuity is optional and should be measured with presbyopic patients who do not wear spectacles for all or certain near viewing tasks, or if it is required for a report. A reading distance should always accompany a near visual acuity, as N8 at 40 cm is a totally different near visual acuity to near N8 at 10 cm. Now we will see about the procedure to test near visual acuity. Sit in front and one side of the patient in order to monitor facial expressions and reactions. Measurements should be made in similar lighting conditions to those the patient uses at home. Ask if the patient uses an angle poise or gooseneck light at home, and if they do, use additional light for your near vision acuity measurements. Instruct the patient to place the near vision card at their normal near working distance. Measure and record this distance. Measure the near visual acuity of the poorer eye first, if a poorer eye is known from previous records or from the case history. Otherwise, measure the right eye first. Use an occluder or patient's palm of their hand to cover the other eye. If using the patient's hand, make sure that the palm is being used, as otherwise the patient may be able to peek through their fingers. Explain to the patient what measurement you are about to take. This may be simple. Now we shall find out what you can see at close distances. Instruct the patient to read the smallest paragraph they can. Unless the patient can see the smallest print, push them to determine whether they can see any more. Prompts such as try and make out some of the words in the smaller paragraph may be useful. Some patients are more cautious than others and only indicate those letters that they can see easily and clearly. Unless you push patients to guess, you could therefore obtain different near visual acuity results depending on how cautious your patient is. Repeat measurements for the left eye and binocularly. The next testing is pinhole testing. The pinhole testing device can determine if a problem with acuity is a result of refractive error or due to another process. The pinhole only allows the passage of light which is perpendicular to the lens and thus does not need to be bent prior to being focused onto the retina. The patient is instructed to view the Snellen chart with the pinholes up and then again with them in the down position. If the deficit corrects with the pinholes in place, the acuity issue is related to the refractive problems. To determine if poor vision is due to refractive error, if vision is better with pinhole, patient has a refractive error. If no improvement, patient has poor visual acuity due to pathology or amblyopic eye. Let us see about levels of severity of vision impairments. Best to correctable Snellen acuity equivalent is mentioned here. Normal vision is 20 by 25 or better. For 20 by 30 to 20 by 60, near normal vision will be mentioned. 20 by 70 to 20 by 160, moderate low vision. 20 by 200 to 20 by 400, they will be noted as severe low vision. 20 by 500 to 20 by 1000, they will be noted as profound low vision. Less than 20 by 1000, they will be noted as near total blindness. No light perception means they will be total blindness. Now let us see about clinical low vision evaluation. The clinical low vision evaluation differs from the medical examination from an optometrist or ophthalmologist in that it provides functional, usable information about the visual abilities of an individual who has low vision. The evaluation focuses on verifying the student's visual acuity and on finding ways to enhance the student's visual functioning. A combination of the visual functioning evaluation and reading media assessment will determine if the student's primary mode is print. A low vision evaluation will further determine if optical aids will provide the students with low vision devices to access print. If the devices are recommended, the teacher or visually impaired will need to instruct the student in the use of low vision devices. Although there are certain components in all low vision evaluations, the focus will depend upon concerns of the student, family and teachers. The individual who conducts the evaluation is the low vision specialist, but others may be involved in the entire visit. The low vision specialist will seek to identify optical and non-optical tools that will increase the student's ease of completing near and distant tasks. The evaluation can provide information that is critical to the kind of educational programming that is needed by students who have low vision. The information from the clinical low vision evaluation paired with the functional vision evaluation and the reading or learning media assessment will provide the team with information that can assist in the student overall literacy program. The following are the areas that provide the procedure need to be carried out during the evaluation are: first one is case history. The specialist will want to know the student medical history and information from the most recent ophthalmological exam. The family will be asked about the onset of visual impairment, eye surgery and dates, current treatments and medication, and about the student's general health. The specialist will also ask about the student's independent functioning at home, in the school and in the community. Next one is ocular health. The specialist will assess the general condition of the structures of the eye in order to determine the nature and extent of the visual diagnosis. The specialist may be able to better explain the visual impairment to the family. The next thing is visual acuity. The specialist will assess the student's visual acuities both with and without correction. Each eye will be assessed separately and then together. Both distance and near visual acuities will be assessed. The next test is visual fields. The specialist will assess the central and peripheral visual fields. There are variety of tools to assess students' fields. These tests can also be used to assist in diagnosing the disease process in some visual impairments. The next test is color vision. The student's color vision will be assessed. This will provide useful information regarding the student's contrast abilities. Refraction and conventional lenses are also to be tested. The specialist will test for refraction to determine if correction can be further corrected. Contact lenses may be recommended as they can sometimes improve acuities of some students with irregular cornea surfaces or with high refractive errors. The next assessment is binocular vision and oculomotor skills. The specialist can determine the potential for sustaining binocularity. The results will have an impact on the prescription of low vision device and training. Fixation, scanning and tracking may also be assessed as well as their head position and visual motor abilities. The next assessment is contrast sensitivity, light sensitivity and illumination needs. Assessment of contrast sensitivity will provide information on the degree of loss of the ability to detect materials when they are presented on low contrasting backgrounds. If the student performs poorly, more attention will be given to issues of lighting, contrast and glare. The next one is low vision devices. The specialist will select possible low vision devices for a student based on the goals of the student along with the acuity outcomes. The specialist may prescribe devices for near, intermediate and distance activities. Recommendations. At the completion of the visit, recommendations for low vision devices are typically made. Some clinics may provide low vision devices for the students to borrow. The students will typically be encouraged to use the devices for a period of time and return for a follow-up appointment where the results can be reviewed. These are the methods used to interpret clinical assessment of vision. This will help to determine educational and functional program for visually impaired children. Thank you.